So we're coming back now. We're going to talk about endocrine. Now, technically diabetes is endocrine, but it's such a big topic that we kind of break it off into its own thing. So endocrine has to do with all of the hormones in your body. So at this time, we're going to take a quick little quiz. Take out a piece of paper.
What?
Take out a piece of paper.
I don't have paper.
All right, fine. Take out your iPad. Take out a fresh sheet of iPad and write down the answers to these questions. List 5 hormones that are produced by your adrenal gland. Number 2, list 8 hormones produced by your pituitary gland. Now I'm going to give you a choice for number 3. Sketch either the thyroid or cortisol feedback loops. All right, are we ready?
No.
Now, in real life, I would actually make you do the whole thing, but because we're on camera, in the interest of time, we're going to pretend that you did this, and we're going to pretend that you all failed it, because that's usually what happens.
Okay.
Anytime. Anytime. So, list 5 hormones from the adrenal gland. We have epinephrine and norepinephrine. Which part of the adrenal gland do those come from? The middle part or the outer part? The middle. What's the name for that?
The cortex?
The medulla. Okay, and then we have 3 that come from the outside, which is called the cortex. So the cortex means the rind or the shell. So that outer part is what produces aldosterone, cortisol, and then sex hormones. In men, it will produce estrogen, and in women, it will produce testosterone. Yes, you produce testosterone. Pretty cool. All right.
Cortisol.
8 hormones of the pituitary gland, and you should separate these out into anterior and posterior. So how many come from the posterior? 2. Oxytocin and ADH, antidiuretic hormone, also known as arginine vasopressin.
Wait, that was posterior?
That's posterior.
Say it one more time.
Oxytocin and ADH, antidiuretic hormone. From the anterior, we have TSH, thyroid stimulating hormone, FSH, follicle stimulating hormone. Oh, yeah, you women don't even know your own hormones. LH, luteinizing hormone. Adrenocorticotropic hormone, ACTH. Prolactin, and human growth hormone.
I have that right.
Whew. Now, apparently there have been some discoveries of more since I took ANP2, but hey, we're going to stick with the classic 8. So, if you don't know these hormones and what they do, it's going to be really hard to do very well on a test about them. So it would be a really good idea to review that. Now, the next thing is sketch either the thyroid or the cortisol feedback loops, because they are exactly the same with just a couple very small differences. So we start in the hypothalamus of your brain, and that is going to release something called thyroid releasing factor, TRF. That is going to travel to the pituitary, which is going to secrete TSH. TSH is going to travel to your thyroid, which is going to release thyroid hormone. Which in turn is going to go back up to the pituitary gland and suppress the amount of TSH. So, This is called a negative feedback loop because the more thyroid hormone you have, the less TSH you produce. Does that make sense? Now, the very first endocrine disorder we're going to talk about is thyroid disorders. And in order to understand thyroid disorders, you've got to understand this feedback loop. Now, there's two possibilities with a thyroid disorder. One is the thyroid itself is diseased. Something is happening in the thyroid that's messing things up. The other possibility is that there's something wrong with your pituitary, and it's the pituitary that's messing things up. So, if the problem is with the thyroid itself, it's called primary thyroid disease. If the problem is with the pituitary, it is called secondary thyroid disease. So in secondary, the thyroid isn't actually the problem. It's just responding to another problem somewhere else in your body, in this case, the pituitary. So the two possibilities you can have for thyroid disorder are you produce too much or too little. If you produce too much, that would be called hyperthyroid. If you produce too little, that's called hypothyroid. So let's examine what could happen if you're producing too little. So hypothyroid. Now, does it matter whether it's primary or secondary, how much thyroid hormone will be produced, more or less than usual? Does it matter whether it's primary or secondary hypothyroid? No. If you've got hypothyroid, it's defined as too little thyroid hormone. So the main thyroid hormone is T4, so you're going to have T4 low. Now the question is, if it's primary thyroid disease, what will the response of the pituitary be? If T4 is low, what will happen to TSH? It'll go up. So in primary, we're going to have low T4, high TSH. If it were secondary, what would we expect to happen? If the cause of the low thyroid is the pituitary is not doing its job right, we would have low TSH. So you can figure out, is the problem the thyroid gland if TSH is high, or is the problem the pituitary gland if TSH is low?
Because normally, if the pituitary gland is working, TSH and T4 go opposite.
I wouldn't phrase it that way, but kind of.
Okay.
The way I would phrase it is, if the thyroid is able to do its job, that's not even right. So if the reason your thyroid is low is because the thyroid can't do its job, then the pituitary will respond by trying to tell it to do its job more.
And so when you increase TSH, should it normally increase?
Yes.
T4?
Under ordinary circumstances, elevated TSH would result in more T4, which would then make things go back to baseline, and they would both be normal. But because your thyroid can't do its job in primary hypothyroid, that leads to an elevated TSH level. Okay. But if they're both low, the reason the T4 is low is because the TSH isn't telling the thyroid to produce enough. Okay. So most of the hypothyroid in the world is actually primary thyroid. In the United States, the cause of that low thyroid is something called chronic autoimmune thyroiditis. Now, what do you think chronic autoimmune thyroiditis would do? Your immune system is attacking your thyroid. And as it kills it off little by little, you're reducing the amount of thyroid hormone that can be produced. So over time, you're going to have more and more symptoms until eventually, well, it's all gone. So what do you think the main treatment for that would be? Give artificial thyroid hormone.
Oh.
Now, it's pretty easy, huh?
Not what they was saying.
Man, that was easy. Okay. Now, worldwide, Go ahead.
T4 or just
We'll talk about specifics of thyroid hormone in a few minutes. But first, we'll just talk about the overall disease process. So, worldwide, the main problem, the main cause of low thyroid is not enough iodine. So, in order to make thyroid hormone, you need iodine. In fact, the main thyroid hormone is called T4. What does 4 refer to? The number of iodine molecules. So T4 is kind of like a carrier molecule, and then it gets transformed in your tissues into T3, which is the more active form. And what does the 3 represent? The number of iodine molecules. So iodine is a relatively rare element in food, and as a result, in most of the world, people don't get enough in their diet. Here in the United States, we supplement salt with iodine. So if you look on regular salt package, it'll say iodized salt. By eating that salt, you're getting more than enough iodine for you to have normal thyroid function. With the rise of Food Network, kosher salt became much, much more popular. And kosher salt is not iodized. So one of the things you got to be careful about if you cook exclusively with kosher salt and you don't have regular salt on your table, or nowadays it's pink Himalayan salt, which actually doesn't come from the Himalayas at all. It comes from like Pakistan. But hey, whatever, it's good marketing. It also doesn't have very much iodine in it, and neither does sea salt necessarily. So if you are into gourmet salts, you may be at increased risk for iodine deficiency. But most of the world, iodine deficiency in the United States.
But is salt the only place you can get it?
It's not the only place, but it's the food it's supplemented in. In the United States, the main cause of low thyroid is chronic autoimmune thyroiditis, also known as Hashimoto's disease. Named after Dr. Hashimoto, I guess. That's my guess. But I've never actually looked it up. So, how do we know a patient's got chronic autoimmune thyroiditis?
Checking their TSH.
Well, the main step would be to look at their T4 and TSH and then know that in the United States that's the #1 cause, so chances are it's that. That's pretty simple, right? Okay. Now, what does thyroid hormone normally do in our body? A lot. Okay, yes. What does it primarily do? It speeds up the rate at which the sodium-potassium pump does sodium-potassium things. Now, what is the sodium-potassium pump responsible for, among other things? We learned it in Pathopharm 1, for example. Cool kids and nerds for action potential in nerve conduction, action impulse. So actually the resting impulse. The faster you can reset a nerve, the more times it can go, right? So it plays a part in helping nerve tissue to nerve tissue correctly. And in fetuses and young children actually helps to mature the nervous system. In the absence of enough thyroid hormone, children end up with a developmental disorder called cretinism. We'll talk a little bit more about that later. So it's partly responsible for nervous tissue and fetal development of nervous tissue, nervous system. It's also responsible, in terms of the sodium-potassium pump, for the production of ATP. So thyroid hormone speeds up almost all the metabolic processes in your body by helping to produce more ATP. It also increases heart rate. So, what sorts of problems might a patient with low thyroid experience? Low heart rate, less energy, fatigue, weakness. Their body temperatures are usually lower because they've got less energy use. Heart rate would be lower. So those are all signs and symptoms of low thyroid. There's a whole bunch of others in terms of like skin and hair and other functionality that you should be familiar with, but the big ones are going to be low energy, weight gain as a result of low energy use, and low heart rate. Okay. Now, what's the treatment for low thyroid? Give thyroid supplements. So what's the main thyroid hormone that's produced? T4, also known as thyroxine. So when we give artificial thyroxine, we're going to give levothyroxine. What does that imply to you? It's the left hand of a racemic mixture. So levothyroxine is essentially T4. Most of the time, T4 supplementation by itself is going to solve the problem. And what do we mean by solve the problem? Okay, so it'll raise T4 levels, it'll lower TSH levels, and resolve the patient's signs and symptoms. Now, what is one of those principles of health assessment we talked about so long ago at the beginning of Pathopharm 1? We don't treat numbers, we treat patients. So just because a person's numbers normalize doesn't necessarily mean we've adequately treated them. We also need to look at signs and symptoms. And there's a small group of patients that even when their numbers normalize, they still don't feel right. And in that case, you can also add in T3. It's like levothyroxine, kind of hard to pronounce. So we're going to call it by one of the main brand names, Saito Mel. So what is Saito Mel? Artificial T3. What is the relationship of T4 to T3? Oh, that's a good question. The amount of iodine in them, okay, yes. Your thyroid produces 99%, which one? T4. The T4 is put out in your bloodstream where it holds hands with proteins. And then it goes through your bloodstream and it gets dropped off at tissues, and then what happens?
Energy.
What?
Energy.
Not yet.
Okay.
It goes to where it needs.
There's enzymes in your tissues that convert T4 into T3. And then T3 is primarily responsible for the thyroid hormone actions. Does that make sense?
So T3 is responsible for the thyroid hormone actions.
Yes. So T4 is primarily a carrier molecule for T3. It's a precursor to T3. It's a prodrug. It's a pro-hormone.
Why would their T3 not why would they treat the T3 instead of T4?
T4 is designed to be carried in your bloodstream.
Yeah.
So it's the preferred drug. It's also safer than giving T3. T3 has a much higher risk of adverse effects. Now, remember we talked about bodybuilders? Yeah. So, what bodybuilders do is they grow larger than usual amounts of muscle, and then they starve themselves to get as little fat as possible, revealing the muscle underneath. As you lose weight, what happens to your metabolism in an effort not to die by starvation?
It slows down.
It slows down. So what bodybuilders will often do is they'll take Saito Mel to keep their metabolic rates higher so that their fat loss doesn't slow.
See?
But that's dangerous. So again, I guess anything to look good. But, although that definition of look good. Anyway, so that's one potential use for Saito Mel. But most of the time, when it's being given medically, what are we going to give? T4. Why? It's safer and it's designed as a delivery mechanism for T3. But there is a small subset of patients where T4 alone is not enough to resolve their symptoms. And in that case, what do? We add in the T3, Saito Mel. Now, what do you think the adverse effects of thyroid hormone could be?
too much?
Yeah, giving too much. What are the symptoms of hypothyroid? Weight gain, low body temperature, fatigue, low heart rate.
Weight loss, increased heart rate, lots of energy.
Wait, it's weight gain.
Yeah.
Weight gain,
Yeah,
I mean.
she's answering the question now.
Oh.
So she was answering the first question. So those are all signs and symptoms of too little. So what are the signs and symptoms of too much?
Weight loss.
High heart rate.
Weight loss, too much energy, feeling nervous, heart rate goes up, dysrhythmias.
Thyroidism? No, if you give too much.
Yeah, yeah. Those also happen to be the signs and symptoms of hyperthyroidism, in case you're wondering.
These are adverse effects of the drugs and
Yes.
hyperthyroidism.
Yes. So the drug is an artificial hormone. So too much drug is going to be identical to a disease of too much hormone.
Okay.
So in super high amounts, we call it thyrotoxicosis, which sounds kind of like thyroid toxicness, which it is. Thyrotoxicosis. Or it's also known by the much cooler name thyroid storm, which kind of sounds kind of like an X-Men or X-woman.
So that could be like hyper, left untreated, or too much treatment for hypo.
Say that again?
I
Yes. Yeah.
Okay, so thyrotoxicosis is when you have so much thyroid hormone that is potentially acutely dangerous. And it's also known by the name thyroid storm. The number one cause of thyroid storm or thyrotoxicosis is T4 overdose, or in fewer cases, T3 overdose. It's relatively difficult to get that much thyroid hormone just by normal hyperthyroidism. So, thyroid storm, what's the number one cause? T4 overdose. Okay, now your patient comes in with hypothyroid symptoms. They get diagnosed with hypothyroidism, and the doctor starts them on levothyroxine. What is it important to tell our patient, to educate them about?
Their adverse effects.
Okay, adverse effects. So if you start noticing these things, come back and we'll check your levels. You might be too high. What else?
It's like a lifelong therapy, so
Yeah.
if they forget to take it, they can't double up on it.
Right, so this is a lifelong therapy. You take this every day for the rest of your life. You also need to tell them what to do if they miss a dose. Now, thyroid hormone is relatively long acting. It's got a very long half-life. So if they miss a dose and take it later that day, not a big deal. But if they skip a day, they shouldn't double up the next day. So, say you take it at 9 o'clock every day. I forgot. And you don't get to take it, so you come back home from work at 5 o'clock, and not really that big a deal. Not ideal, but not a deal breaker. But if you miss a dose completely, don't double up on the dose the next day, because that can make you go acutely high, and that would be bad. But one of the key things to educate patients on, lifelong therapy. This is not a cure. It's replacement therapy for a hormone that your body can't produce enough of. Does that make sense? All right, so now let's talk about hyperthyroid. So with hyperthyroid, what's the problem? Too much thyroid hormone. Now, one potential cause of hyperthyroidism is too high a dose of your levothyroxine. So anytime a patient has hyperthyroid symptoms, one of the things you want to do is a good drug history and past medical history. Because maybe they're not hyperthyroid at all. Maybe they're overdosing on their hypothyroid drug. But the hallmark of hyperthyroidism is going to be elevated T4 levels. Now, if the problem is the thyroid itself, what is TSH going to be? So if it's primary thyroid, what will TSH be? Low. If it's secondary, then what will it most likely be? Elevated TSH. So, for example, you can get a tumor of the pituitary gland called a pituitary adenoma. And pituitary adenomas will often produce one of the pituitary hormones. So if the hormone it's producing is TSH, that's going to cause increased levels of T4. Question?
I'm sorry. I'm still confused. So secondary is with the pituitary gland.
Yes.
So if you have hyperthyroidism and you have increased T4, why is it going to?
You were here. I think you must.
What?
You were saying something different a little while ago.
Oh no, but that's for low T4 though.
Yeah, you said
No. No, I said it the same way.
Low T4 and high TH is primary.
No. Okay, before we were talking about hypothyroidism.
Right, okay.
Now we're talking about hyperthyroidism.
be high for both secondary and primary.
So your T4 will be high.
T4 is going to be high for both, yes.
Okay.
Yeah, I'm confused as to why TSH is high for secondary.
Hold on.
Oh.
Yeah. So, in secondary, the thyroid is normally functioning. It's just doing what it's told. And it's being told by the pituitary to produce more thyroid. How does the pituitary tell it?
Yes.
With TSH. So high TSH causes the high T4. That's secondary. What's it secondary to? The pituitary secreting too much TSH.
Oh, so the pituitary is secreting too much TSH.
Yes. So this, in secondary, this is causing that.
Okay, so but when the thyroid.
But when the thyroid is the problem, the thyroid spontaneously is producing too much, that's going to suppress the pituitary and lower TSH. Does that make sense?
Yeah.
Okay. That's why being able to sketch the thyroid feedback loop is so darn important. And you thought it was just a quiz. By the way, you're supposed to put the number right at the top and then give it back to the person who took the quiz and say, let this be a lesson. So, and the lesson is you probably don't know your hormones as well as you should. So, the number one cause of hyperthyroidism in the United States is called Graves' disease. Now, Graves' disease is an autoimmune disease where there are antibodies that act as TSH. They're able to bind to the TSH receptors in the thyroid and tell the thyroid to produce more thyroid hormone than usual.
So it's a primary or secondary?
It's considered primary. Yes, I know. The thyroid is just doing what it's told, but it's not coming from the pituitary, so we call it a primary thyroid disease. Don't worry about it. Don't worry about it. So, in Graves' disease, you're going to get all of the hyperthyroid symptoms that we talked about. So weight loss, cold or heat intolerance, agitation, heart rate goes up, all those things will happen. But your patient will also typically experience what's called exophthalmos.
How do you spell that?
So exophthalmic with an X at the front. So, yeah, don't ask me how to spell ophthalmic. I always spell it wrong. But something like this. So, exophthalmos, also known as bug-eyed. So, there's an accumulation of those antibodies behind the eye, which pushes the eye forward, giving a person a bug-eyed appearance. They'll also typically have some thyroid enlargement, so they'll have some goiter. So what are the three kind of signs of Graves' disease?
Goiter, bug-eye.
Goiter, exophthalmos, and hyperthyroidism.
So the disease in itself is
So the underlying disease is an autoimmune disorder.
yeah.
And that autoimmune disorder results in those three things happening.
Okay.
So there are some other causes of hyperthyroidism, but we're not going to talk about them. What we're going to talk about is the treatment of hyperthyroidism. So the first thing is you can use some drugs to lower or block the effects of thyroid. So it's PTU. And we're not, that's all we're going to say about it.
Which does
Lowers.
what?
It lowers the effects of thyroid hormone. The drug name is abbreviated PTU. That's all we're going to learn about that. The main treatment is going to be to kill or remove, or both, part of the thyroid gland.
Oh,
So how would you remove part of the thyroid gland?
surgery.
Surgery. How would you kill it? Chemotherapy?
Therapy.
All right. So is there a substance that is used only by the thyroid gland?
Radioactive iodine.
Iodine. So by giving radioactive iodine, it will concentrate in the thyroid hormone, in the thyroid, killing it. Now, the key is we want to kill just the right amount. If you don't kill enough, what happens? You're still hyperthyroid. If you kill too much, then you're hypothyroid. And if you kill just the right amount, you're perfect.
Are we only treating this to like avoid the signs and symptoms? Or are we treating this for like, will it kill someone if they don't treat it? I don't get it.
In severe cases, it could kill a person directly. It can also lead to a number of potentially bad complications like heart dysrhythmias. But the main reason is that patients don't like the way they feel. So you're treating essentially the symptoms. So what we want to do is, like Goldilocks, kill or remove just enough, but not too much. Now, which one is better? Too much or too little?
Too little.
Too little.
Too much.
Oh.
Because then you just treat them like they have hypothyroid. Here, take this levothyroxine. If you don't remove enough, they still have symptoms. So, now, what are the advantages of radioactive iodine? Well, it's cheap. It's also very safe. But it takes a couple weeks before it really starts working. What are the advantages of surgery?
You didn't know you did it.
It starts working immediately. But there are some risks because it's surgery. There's a potential for death. There's potential for bleeding. There's a potential for infection. And the person will end up with a nice scar. Or not so nice. You can take that scar and put some pretty cool tattoos around it. So anyway, those are the main issues with surgery versus the radioactive iodine. Any questions about those? All right, so at this point, we're done with thyroid hormone. Oh, sorry, lies. Cretinism. So,
What's that?
cretinism is something that can occur in children who do not have enough thyroid hormone as children. So, we need thyroid hormone in order to grow normally and also in order to develop the nervous system. So children who don't have enough thyroid hormone end up with this thing called cretinism. They're very short. So there's a picture in your notes of like 4 boys all standing next to each other. And one of them is like, normal height and the others are all like this height. Those kids are all 15 years old. So the other ones, they never grew because they had cretinism. They typically will have tongues that are too large for their mouths, so it look kind of like this. And there will be profound mental retardation. The word cretinism comes from a French chrétien, which means Christ-like. And the reason they were called that is because they were so innocent that it was thought that they couldn't possibly sin because they don't have enough brain power to be able to know right from wrong. So that is cretinism in a nutshell. It is completely preventable if you can tell that a person has low thyroid levels as a child or as a baby. You can supplement it and they'll grow up normally. One of the things that we screen kids for here in Florida at birth is hypothyroidism.
By checking those levels.
Yep. Hypothyroidism is also an important factor in during pregnancy. For the first several weeks of a fetus's life, it relies on the mother's thyroid hormone, but very quickly on, they produce thyroid, and then they can produce their own thyroid hormone. So it's only critical in the first couple of weeks of development, and then after that, kid produces their own. But it is the potential for complications in mothers who have hypothyroidism when they're pregnant. All right, any questions about thyroid hormone? All right, next we're going to talk about cortisol. So cortisol has a very similar feedback loop to thyroid hormone, except instead of TSH, it's going to be ACTH. What does the ACTH stand for? Adrenocorticotropic hormone. Right! You forgot it between now and when I told you that on the quiz. These things happen. That's what happens when you don't remember stuff from ANP2. So, adrenocorticotropic hormone, released from your pituitary gland, goes down to your adrenal glands and tells your adrenal glands to produce hormones. The main hormones produced are going to be cortisol. So in the adrenal cortex, you produce both mineralocorticoids, the number one of which is aldosterone, and you also produce corticosteroids, the number one of which is cortisol. But there are some others, but we're not going to worry about that. For our purposes, you've got aldosterone and cortisol. We're not going to talk about aldosterone at all for this test. We are going to talk about cortisol. So, what are the effects of cortisol on your body? This should be a review from Pathopharm 1, just so you know.
Sympathetic response?
No.
It's
Okay, so, all right, hold on. Okay, so, sympathetic response is one of the triggers for the release of cortisol. Okay. So, sympathetic response helps to stimulate cortisol production. But what does cortisol actually do in our bodies? Yawning is not one of the answers. So, what is the name of the thing? Corticosteroids, which are also known as glucocorticoids.
Oh, metabolism.
Of glucose. Okay, so the first thing is helps to raise glucose levels. What else does it do?
Breaks down.
Sodium?
Increased sodium levels, which in turn leads to increased fluid retention, which in turn can cause increased blood pressure. Okay. So these are all some of the effects. It also has an increase in lipid metabolism, or dystrophy anyway. It has a tendency to suppress protein metabolism and has a tendency to decrease T cell function. Do you remember all that? Nope. It also has an effect on appetite, has an increased appetite. And it also helps to increase muscular blood flow. Yes, we went over all of this in Pathopharm 1.
You're lying.
Don't remember that? I actually had the video to prove it.
That's what he said last semester. You guys are gonna keep going. You're gonna be like, It's like
Yes, you do.
it's like
Because what are the adverse effects of steroids?
Toothpicks on a lemon.
What?
the moon phase,
Cataracts.
buffalo hump.
Elevated blood sugar, elevated blood pressure, elevated blood sugar, elevated sodium levels, moon face, buffalo hump, and central adiposity, muscle wasting, and decreased wound healing.
Okay.
All right, fine, shut up. Osteoporosis,
Cataract.
weight gain, cataracts, that's not part of this, but yeah.
Surprised I remember that.
And suppression of inflammation.
Is there some type of retardation?
No. No. Retardation we talked about in the context of, what do you call it? PKU.
Oh yeah.
And then we also talked about it in the context of, well, just now in the context of thyroid hormone. And we also talked about it in the context of Rye syndrome. But anyway, so these are all potential things that can happen. Now, when does a person have too much too much cortisol production?
Sympathetic response.
Okay, too much sympathetic response is actually not the answer. You will have slightly elevated cortisol levels from chronic stress, but it's not going to cause huge problems. It will lead to ultimately have some issues.
Growth retardation. There was retardation.
Say again?
Increased ACTH.
Okay, so when would a person produce too much ACTH, potentially?
That thing doesn't work.
A disease. What disease would that be?
The one that ACTH.
Well, what's it called when you have a tumor of your pituitary,
Pituitary tumor.
a pituitary adenoma? And if that pituitary adenoma produces ACTH, it can result in too much of that. What's that called?
Cortisol effect.
It's named after a person. It sounds like something you'd put on a couch.
Cushing's disease.
Cushing's disease. So, Cushing's disease. Cushing's disease is all of that, plus the cataracts, plus the osteoporosis, which we haven't mentioned yet, poor wound healing, all of that stuff is Cushing's disease. And disease is when we have too much what?
Cortisol.
Too much cortisol because
Pituitary tumor.
of a physiological process in our brains, usually, pituitary adenoma. So the treatment for it is typically to cut it out. Cut it out! How would you cut out the pituitary?
Surgery.
Surgery. Where is the pituitary?
In the brain.
Ooh.
So they actually go up your nose. Well, ideally it would go up through your nose,
Okay,
because then there's no
let me
scar.
backtrack for like 5 seconds.
Okay, go ahead.
Cushing's, so how that happens is from a pituitary adenoma.
Very often from a pituitary adenoma.
Okay, and then that
Addison.
makes the increased ACTH. Okay.
Which stimulates your adrenal glands to produce too much cortisol. So that's Cushing's disease. What about Cushing's syndrome?
Oh my gosh.
That's when you have the symptoms.
That's when you have all of these things, but it's not because of a pituitary adenoma. In fact, you might have low cortisol levels. Oh, now it's a medical mystery.
Now we're stuck.
What could cause that? Well, yeah, I mean, that's why you have low cortisol. But how would you have all those symptoms of too much cortisol, even though you have low cortisol levels?
It's about aldosterone.
You got this one, Shelby. Say again? Moon phase. Okay, and what was moon phase in the context of originally? From Pathopharm 1. It was, okay, lipodystrophy as a result of what? It was a drug, right? Steroids. So when you give steroids, your body stops producing ACTH because it says, well, there's enough steroid around, right? There's enough cortisol. So what is Cushing syndrome?
Oh. So you have like low.
It's all of these things caused by adverse effects of steroid drugs. So if we, with our treatment of steroids, are causing Cushing's, it's a syndrome. If the body is naturally producing it as a disease process, then it's Cushing disease. Ah. Now,
So you just take them off the medication?
Because they have the same
Yeah.
effects. They're
Yeah.
by different things.
The disease is actually
yeah.
physiological.
So to cure Cushing syndrome, you got to take them off the steroid. To cure Cushing disease, you have to fix the underlying problem, which is often surgery of the pituitary. Not always, sometimes.
Do they cut out the whole?
No, they reduce the amount. Yeah. We had a student a number of years ago who had had Cushing disease when she was a teenager. And she would never show us pictures, but she's like, I was like a blimp, like exactly like you described with everything. And then once she had the surgery, she's this tiny little skinny thing. And the difference was the amount of hormone. Okay, now what happens if we've given this patient Cushing syndrome and we suddenly take all the steroids off? Stop giving them steroids.
They're not going to make any, right?
They're not going to make any what?
Cortisol.
Cortisol. And then what happens?
You get
Withdrawal, acute adrenal crisis. So in acute adrenal crisis, that's something that we create by putting them on a steroid. The body stops producing ACTH. We take them off the steroid suddenly, and now there's no cortisol production at all. What are the signs and symptoms? Well, see all these arrows?
Flip them.
Just flip them. So instead of too much blood sugar, the patient will have low blood sugar. Instead of too much sodium, they will have low sodium. Instead of high blood pressure, they will have low blood pressure. So it's potentially deadly. How do we solve that problem?
Taper it off.
Put them back on the steroid and then taper it slowly. Now there is a disease where a patient can have low cortisol levels naturally. And that disease is called Addison's disease. So Addison's disease is going to be characterized by all those symptoms we just talked about. Low blood sugar, low blood pressure, low sodium levels, fatigue. Patients will be sleepy a lot, and they will often have hyperpigmentation of the skin. The treatment for it is going to be to give steroid drugs. Now, which kind of steroid drug do you think we would most likely give? Would it be
The one that's
prednisone
too.
or cortisone?
Cortisone.
Why?
They have low cortisol.
Because it's less potent. Okay. All right. Any questions about
It would be hypoglycemia. No, glycemia. Hypoglycemia.
Yes. All right. Any questions about cortisol stuff? All right. We are going to really quickly go through the last few in the next 3 minutes. So, if a person has too little growth hormone as a child, what will happen? They get short. If they have too much as a child, what happens? They get really tall. It's like gigantism. And they may end up with Osgood-Schlatter syndrome. That's where their bones outgrow their muscles. If a person has too much growth hormone as an adult, what happens?
Nothing.
They get overgrowth of the bone in their face. It's called acromegaly. Okay, next we have ADH, which is going to tie into a little bit of renal. But if a person does not have enough ADH, they end up with something called diabetes insipidus. All of their fluid leaks out, and they have high sodium levels in their blood. As an alternative, they could have too much ADH. That's called syndrome of inappropriate ADH, SIADH. And you basically have the opposite. Low sodium levels and too much fluid in the body. Next, we have prolactin. if prolactin levels are too high, the patient will end up with a collection of symptoms. But prolactin is one of the things that causes breast milk production. So a person will end up with galactorrhea, which means breast discharge.
Even if they're not.
Even if they're not breastfeeding. Not will, but could. Women will also typically have decreased libido. And they will have suppressed periods. If it happens as a teenager, it can delay the onset of menarche. What is menarche? The age of first period. So it's fairly common for women with hyperprolactinemia to end up 15 or even 17 and not have had their first period yet. So one of the reasons why it's important to know this is if you have a woman who has very light, very irregular periods, breast discharge, and no libido whatsoever, do you think that makes for a very happy marriage?
No.
No. So there are treatments. Oh, it also can cause infertility. So there are treatments, and the main treatment is a drug called cabergoline. What is it? You should know it.
We already did this.
I know. It's a dopamine receptor or agonist. So it's one of the treatments for Parkinson's disease. It's a dopamine agonist. But it will suppress the levels of prolactin, which will help their libido and help them get pregnant, which makes for a much happier marriage. Not necessarily the pregnant part, but the,
You did this.
the feeling like you actually want to respond to your husband, who you say you love, but he's like, but you don't love me. Say again? Cabergoline, which was the only dopamine agonist that you guys had to remember, non-ergotamine. All right, so on that note, we are going to be done with today's lecture. We haven't done the contraceptives, so next class we will continue with contraceptives, and then we'll do the musculoskeletal and then the renal. And then we should be able to get all that done on Tuesday.
Do we need to know prolactin too low?
Prolactin too low? No.
Okay.
Yep. I guess that would just result in decreased milk supply.
If
All
you
right.
have prolactin too high when you're
Today's class to you brought by Cherry Coke Zero.
Would you get a haircut?
No, I got them all cut.
Oh my god.
She's like, I don't get it.
I don't get it. You actually got a haircut. He got them all cut.
And the joke is terrible, but your reaction is quite
They
funny.
say mall cut. And I was like, what is a mall cut?
Them all
I got them now.
cut. Yeah. Okay. So a mall cut is the best. You should so try it. We gotta cut this stuff out.
No, leave it in. It's the best. It's like what I live for in your podcast sometimes, like just a joke. No, you gotta
This is not exactly a joke.
okay.
Leaving it in would be a sick joke. All right, last class, at the end, we breezed through the miscellaneous endocrine disorders, and many of you went like this. So we're gonna recap them ever so quickly now. Again, so the bulk of our time talking about endocrine disorders was diabetes, and then we also talked about thyroid disorders in a certain amount of detail, and then a little bit less detail, we talked about cortisol disorders. So too much or too little. If the cause of too much cortisol is artificial, so drugs, then we call it Cushing syndrome. And if it's a physiologic mechanism inside the patient, then we call it Cushing disease. And one of the most common causes of that Cushing syndrome or Cushing disease is a pituitary adenoma, and if you can remove the adenoma, a lot of times that will resolve the problem. So then we talked about then we had not enough, which was Addison's disease. And we can also create that acutely in a patient, not the disease, but the condition of not enough cortisol by withdrawing steroid drugs suddenly. And that's called acute adrenal crisis. And of course, the solution would be to put them back on the steroid and then taper down. So then we had a couple of miscellaneous disorders. So the first one is for growth hormone. So for growth hormone, if you have too much of it as a child, that'll result in gigantism. It can also result in Osgood-Schlatter syndrome, where a person's bones grow faster than their connective tissue, the muscle and the ligaments and tendons. No, that's something different. So acromegaly is something that can occur when a patient has too much growth hormone as an adult. And what happens as an adult is you get an increase in the amount of bony growth, but it's not length anymore. So you're not getting taller, you're just getting more bone deposition. So a lot of times they'll have faces that have, bony overgrowth. So they end up looking a little bit like the Hellboy look,
So what was
without the skin color and horns.
So gigantism, or what was the other one that you said?
What other one?
Before acromegaly.
Osgood-Schlatter syndrome. It's not going to be on your tests. But if you're a pediatric nurse, you might want to know that for later. All right, and then if you don't have enough growth hormone, that results in dwarfism. All right, next we have hyperprolactinemia. So if prolactin levels are elevated, that can lead to a number of symptoms. So the first one is delayed menarche. So menarche is the first onset of menses. So ordinarily in today's age, used to say it was like 13 to 15, but in today's age of modern nutrition and everything, a lot of girls are beginning to have their menarche at even younger ages, as low as 9 years old sometimes. But in hyperprolactinemia, a lot of times they'll have menarche delayed until they're 17 or even later. A lot of times we don't know when the natural onset is, because one of the kind of natural things that seems to happen nowadays is, oh, you're not having your period? Here, let's put you on birth control pills, which we'll talk about a little bit later. And then birth control pills make it look like you're having a menstrual period, even though you're not actually. So are you having menses? Yeah, sure looks like it, but it's not actually menses. So we don't even know when their actual true age of menarche is a lot of times nowadays because of that practice. So the second thing that can happen is they can have galactorrhea, which is breast discharge. And they can also have decreased libido. And they can also have difficulty becoming pregnant. So if you have a young girl who has that kind of collection of symptoms, then they can be treated. And so a lot of times, what will happen is that girl gets married and she wants to enjoy sexual relations with her husband, but she can't. And then she wants to have a child, but she can't. And so she can live quite unhappily. Well, they can live quite unhappily because neither of them is having much fun, and then they can't have a kid on top of that. And both of those issues can be resolved a lot of times with treatment. And the treatment of choice is a dopamine agonist called cabergoline or cabergoline. So in a room full of young females, such as in nursing school, a lot of times there's at least one of them who actually has this. And so a lot of times it's not just for your patient's sake, but for your classmate's sake as well. I think that was all of them that I did. Was there others?
Antidiuretic hormone?
Oh yeah, ADH. So ADH, antidiuretic hormone, is responsible for allowing the kidney to concentrate urine. So if you have too much ADH, we call it SIADH, what will happen is the patient will have urine that is very, very concentrated. So your body excretes sodium into the urine, but doesn't allow the urine to be, but reduces the amount of urine being secreted. So what's going to happen is you're going to have the opposite of what you usually expect. What we usually expect is sodium follows water. Sorry, other way around. Water follows sodium. But in the case of ADH, you have the opposite. So you're going to have a patient retaining water, so high blood pressure, but they're going to have low sodium because the sodium is being excreted into the urine. And then the opposite of that is if you have too little ADH, you end up with what's called diabetes insipidus. So remember, diabetes does not mean high blood sugar. What does diabetes mean? Means fountain. So diabetes mellitus is high blood sugar, but diabetes by itself just means flow. And so insipidus, it means that your fountain of lots of urine doesn't have very much sodium in it. So in this case, the body is retaining sodium, but peeing out all of the water, so you're gonna end up with a patient who's got low blood pressure and high sodium. Any questions about those hormonal issues? You guys are all a little too close to me now. I'm like, I'm used to having some space. All right, so at this time what we're gonna do is we're gonna move on and we're gonna talk about contraceptives real quick like. Now, there's a number of ways that contraception can occur, and one of the natural ways is called the rhythm method. So what is the rhythm method? You guys don't know? So in the rhythm method, what you do is you basically count the number of days from when a woman has her first day of period, and then you wait until about day 12 or so, and then you don't have sex for the days that she's probably ovulating, and then you have sex again after that. So that's a strict rhythm method. It's just based on the number of days after menses begins. So remember, a period is the first day of bleeding. That's the first day of the last menstrual period. So that's one way of doing it. And the problem with that is it doesn't work very well. So there's a name that we have for people who use that method of birth control, and it's parents. So another way of doing it is a hybrid method where you don't use birth control except for the days that you're most likely to be ovulating. And there's a number of ways that you can test whether a woman is, not test, but a number of ways where you can predict when a woman is ovulating. So one is the number of days. Another is by body core temperature, or body temperatures. So you take her temperature every day before she gets out of bed. And so you'll see the temperature changes right before ovulation. So you either refrain or use another method of birth control during that time. And then another way is with the stretchiness of cervical mucus. So cervical mucus is more viscous, less thick during ovulation. And the purpose of that is to allow the sperm to have an easier time getting through. So those are some methods that you can use to kind of predict when ovulation is going to occur. So they can be used to try and avoid pregnancy, or you can use them to try and become more pregnant.
More pregnant.
Yeah. If you're wondering, like, when's the best time? Well, that's the best time. Okay, so rhythm methods are either refrain from sexual contact during that time, or use another method of birth control. Next, we have condoms or barriers. And condoms, they say, work 97% of the time when used correctly. However, the in practice rate of, like under not perfect conditions, under regular human conditions, is more like 70%. So there's an old joke there, which is what do you call people who use condoms as their birth control method? You know the answer. Parents. So, but condoms are an option. You can also use condoms. Most of the condoms nowadays also have spermicide in them, and so you got that too. So then there's another barrier called a diaphragm. And
Those numbers?
No. You just need to know that they don't work very well. One of the things about condoms, most male condoms are, latex. And so first of all, there can be allergies to latex. Then you can use a polyurethane one, but those have other issues. But the problem with the latex condom is that latex breaks down over time. So first of all, your condom can't be too old. Second of all, condoms break down with both pressure and heat. So where can you keep this condom then? Can't put it in your wallet, because what does the wallet do? Pressure. Can't keep it in your car, not in Florida anyway, because what's the temperature in a car? It's like 150 degrees in the parking lot. So one of the problems with just the condoms is, where do you store it? Now, if you're talking about married people, well, you keep it in your medicine cabinet, I guess. If the woman keeps it, I guess a purse is a much better place, although you might never be able to find it again. But hey, at least it wasn't damaged by the heat. But when you're talking about single people who are just looking for sexual partners, you run into that problem of they might not be in the best condition at the time they're being used.
Just for the hybrid method real quick, are there certain birth controls that you would only take when you are ovulating?
Not that you would take, but that you would use. So for example, you would use a condom only when a woman's predicted to be ovulating.
I thought you meant like actual.
Yeah, so that'd be the rhythm method. Yeah. So in the rhythm method, it's not that you take hormonal birth control at that time, it's that you use another method at that time. So usually a barrier method.
Got it.
You can also, there's also a cervical cap and cervical diaphragms. So basically they're both barriers that go inside the woman's vagina. A cap is kind of like a little cap supposed to sit on top of the cervix. And then a diaphragm is kind of like, it's like a little piece of rubber that's surrounded by kind of like a ring that it expands open. So you pinch it shut, insert it inside, and then it pops back open. And the idea is that it's going to prevent the sperm from getting up inside. You can also combine both of those with, spermicides. And the problem with spermicides is that some people can be allergic to them or have just, kind of like contact dermatitis issues with them. I think there's only one that's currently on the market in the United States, and that's Naloxone 9. I want to say 9. You can tell I don't do that lecture very often, just once a year. So anyway, the most effective birth control method by far is, well, at least most widely used that's effective, is hormonal birth control pills. So most pills are a combination therapy of estrogen and progesterone. So in the combination, the estrogen is mainly what's doing the job, and then the progesterone is there for another reason. And that reason is if you give estrogen to a woman who has a uterus, which, where do babies mature inside a woman?
Uterus.
Oh, so if you're taking this as a birth control, she's gonna have a uterus, right? Right, okay, just making sure. So if you give this estrogen to a woman with a uterus by itself, there is a higher likelihood that the woman will go on to get endometrial cancer. What is the endometrium? It's the inside lining of the uterus. So we don't want to ever give estrogen by itself to a woman who has a uterus. So we give it along with progesterone, which will reduce that risk of cancer back down to basically baseline. In some cases, it can actually be slightly protective of cancer. Now, progesterone has a number of issues. And they're not the most pleasant thing to take. So there's several different generations of progesterone. The original progesterone, hydroxyprogesterone, was actually derived from testosterone. And so not only does it affect progesterone receptors, or progestin receptors, it can also activate block testosterone receptors as well. So it's pretty nasty stuff. And then there's a second, third, and fourth generation. The fourth generation is typically the best in terms of it's the most like regular progesterone and has the best effects. So if you ever hear, your birth control can actually help your acne, only if it's the fourth generation. So the fourth generation progesterones are kind of like the best tolerated. An example of that would be Yaz. You guys don't have to memorize any drug names for this particular test. You just need to know that in general, there's 4 generations of progesterone, with the first one being like the dirtiest in terms of the most adverse effects, and then the most recent being the least amount of adverse effects. And by blocking androgenic receptors, can actually enhance certain things like reducing acne, because acne is caused partially by testosterone in your bodies.
What receptors does it do?
Progesterone, or progestin.
Okay.
So progesterone is artificial progestin.
Oh.
So progestin receptors, and then also testosterone receptors. So first generation activates testosterone receptors in addition to progesterone receptors, whereas the most recent ones don't have that androgenic effect. So they'll actually have decreased androgenic effect, which can lead to better skin, less acne. And in general, women who take the fourth generation just are happier with their pills than the ones who take first generation. The second and thirds are kind of in between, but it's not like a steady progression. You don't need to know all of it. Just know that in general, which will be the best? The fourth. Which will be the worst? The first. Okay.
How can you tell if it's like a fourth generation or first generation?
I forget the actual name of it, but I can send it to you. Yeah, I guess I could actually make it into like a slide. Okay, but yeah, you'll get the slide. But again, you don't need to know it for the purposes of the test. You just need to know that there are generations. So there's only one of the 4th generation, and I'm just drawing a blank on its name at the moment. It starts with a D. But anyway, you guys will have it for your slides later. Not today. All right. So most of the pills are given on a 3-on, 1-off schedule. What does that mean? So 3 weeks on the pill and then 1 week off. Now, a lot of times the pills will come in like, you get like 4 little rows of pills, and then the 4th row is a different color. Why is that?
It's a sugar.
Okay, so it's not necessarily sugar, but it's not active ingredient. So why do they give you a pill if it doesn't do anything?
To remind you to take it.
To remind you to take it, because they know that if you get out of the habit of taking it for a whole week, you might forget to do the next pack. And when you don't take it, it doesn't work very well. Okay, so so what happens when you go onto the off week? Okay, do you get a period?
No.
No. What is a period? But it looks like a period. That's the point. So what is a period? What's the purpose of a period? Okay. Right, so as you went through the month, assuming we're all women in the room now, as we went through the month, the endometrial lining thickened. What's the fancy word for when you get more growth of a cell? Hyperplasia. So there was a hyperplasia of the endometrium, and it was preparing for what?
Baby.
For a baby. But then you don't get pregnant. So do we need that hyperplasia anymore? No. So now we're going to slough off that overgrowth of the endometrial cells, and then we're going to prepare again for the next time. So that sloughing off of the cells, that's where a period comes from. It's also partly why women get cramping, because your uterus is going like this, trying to get rid of those cells. So during this week, did you have that proliferation, that hyperplasia of the endometrium when you're on the pill?
No.
No. So are you actually having a period?
No.
What are you having? Not breakthrough bleeding. That's when you bleed mid-cycle.
You're having
Bleeding mid-cycle would be breakthrough. What you're having is a withdrawal syndrome. So when you give a woman progesterone for a certain amount of time, and then you take the progesterone away, she'll have withdrawal bleeding. So why are we having withdrawal bleeding? Why do we prescribe it that way? Say again? Because it looks natural? Because it feels natural?
Natural period, but not.
There are a number of theories as to why it was done, but one of the major ones is that it looked more natural. And so by making it look like a period, it enhanced the acceptance of contraceptive pills.
As opposed to making it look like what?
As opposed to doing it more like this. 4 on, and when would you ever have bleeding? Never.
So it's okay not to bleed?
No, then
Is it okay not to bleed?
every month. they
Is
do that
it
they're
is it
supposed to
okay not to ever bleed?
Yeah.
Yeah.
Well, they do sell one now that is, I think it's like 86 days on, 3 days off, or maybe 87. So you only bleed for 3 days out of every 3 months.
Why?
Because why would you need the 3 days? So some people think that our bodies, again pretending we're all women here, our bodies need to have that withdrawal bleeding every now and then to kind of like reset things and make sure that the uterus is cleaned out. But is there any good evidence to say that it's needed? No. So it's a guess. And some people actually take their pills continuously and never have periods ever.
So it's like, if you're pregnant, will you have the withdrawal bleeding? When because there's a chance you miss your pill.
Oh, good question.
Say that again?
It's not a period, so you still have withdrawal bleeding if you're pregnant, if you got pregnant on the
Like
pill.
if you forgot it.
Okay. Yeah. So if you become pregnant, the way that your body sustains the pregnancy, is partially by increasing progesterone levels. So the answer is no.
Oh.
So you wouldn't bleed.
Yeah.
So would it?
And that is another function of doing the week off, is that by bleeding, you know you're not pregnant.
Oh, so
Yeah.
if you do bleed, even though it's not a period, you're still not
Right.
pregnant. Okay.
Yeah.
Okay, so that was kind of my question. Oh, sorry.
Yeah, if you're on a contraceptive and you are pregnant, like, so that could kill the baby? Or?
Okay, so how does the pill work? The very first way it works is by suppressing ovulation. But sometimes you can still have ovulation. So at that point, the uterus is not proliferated, so it's not a very friendly environment for that little zygote. So it'll inhibit the potential for implantation. Now, is that a miscarriage, or is it an abortion, or was it never a pregnancy at all? Because when does a pregnancy begin? It begins at conception. But when is conception? Is conception fertilization, or is it implantation? So technically, you're not really pregnant until implantation. But there are some people who believe that it's still wrong that you could potentially kill a fertilized egg.
So would birth control kill a fertilized egg?
Potentially.
But it doesn't stop.
It's not that it kills it, but it inhibited
Allow
it.
it to-
It didn't allow it to implant because it was not a very good environment. So there are some religious people who say, well, you can't ever do the pill because of that risk. But the vast majority of people in the United States, religious or not, have said, nah, I'm gonna take that chance.
Is it true that like if you take say you miss your pill for a few days and then you take it like 3 times, that it's like technically like Plan B?
We'll talk about emergency contraception after this.
I've heard that.
Yep.
So anyway, that's basically how it works. Then as you guys kept mentioning breakthrough bleeding, so just breakthrough bleeding. There's a number of preparations of estrogen, progesterone at different levels of estrogen. So you typically would start at the lowest level of estrogen, and if a woman has bleeding mid-cycle, then you'd increase it to the next dose up.
But why do you have bleeding?
Because you didn't have enough estrogen to suppress everything.
To suppress
Your body's natural stuff. That's all we need to know for
I'm gonna
now.
write that.
Yes, we don't need to be more technical than that at this moment in time.
Body's natural stuff.
Next, so this was combination therapy. So it's got estrogen and progesterone. Next, we have progesterone only. And the first one of these that came around was called Depo-Provera. And in Depo-Provera, what you do is you get an injection once every 13 weeks. And it completely suppresses ovulation.
Injection counting every 30?
Every 13 weeks. So how many weeks are there in a year?
52.
And if you take 13 and you multiply it by 4, what do you get?
I don't.
Close to 52. No, actually it's by 5. Yeah.
None of us right.
So anyway, yeah, that's right, 13 by 4. What do you get?
52.
Is it 52?
No. Yeah.
Yeah, 52.
It's amazing. 3 times 4 is 12. 52. It's amazing. Higher math. So it's going to suppress ovulation altogether, and it's also going to suppress period altogether. So what's interesting is that people who already are practicing this, by people I mean some healthcare providers, who are already practicing suppressing ovulation completely in women who are getting their Depo-Provera, are sometimes hesitant to also do that with the estrogen-progesterone combination. So I would just call that a little bit of cognitive dissonance personally, but hey, whatever.
So you only do one or the other?
Yeah, you're not on a progesterone only and a combination at the same time.
The shot in your arm?
Yes.
No, I didn't know.
Yeah. Well, I mean, it doesn't have to be your arm, but
I didn't know. I don't.
yeah, it's an intramuscular injection.
Okay.
Okay. They also have ones that are implantable under the skin as well. Now, when it comes to progesterone only, the number one adverse effect is going to be weight gain.
Oh.
And remember we said that the first generation were the most unpleasant, and Depo-Provera is medroxyprogesterone. It's that first generation, so it has a number of more unpleasant adverse effects.
We don't need to know that name.
No. No, you don't need to know the name.
Why does progesterone only make you gain? As opposed to like both of them together?
Because it's a much higher dose of progesterone. You're in an estrogen combination, you're really just relying on the progesterone to suppress the risk for endometrial cancer. It's the estrogen that's doing the actual work of the contraceptive. So, and that brings us to an important point with estrogen, is that estrogen can increase the risk for blood clots, especially in women who smoke. So a lot of providers will not prescribe birth control pills, the estrogen birth control pills, to women who smoke for that reason. So increased risk of DVT. All right, there's a number of other delivery mechanisms available currently. So there's a patch. So in the patch, you're supposed to put it in this area, and it absorbs through the skin. What's that called? Transdermal, and then affects estrogen levels. And there's also a ring, the Nuva ring. It's a little plastic ring that's impregnated, pun intended, with the drug. So you insert it up into the vagina, and it releases the estrogen and progesterone directly to the vagina. So the idea with those is that you can get a slightly lower dose because it's being administered closer to the site of action than when you take a pill by mouth and it's going throughout your entire body. They're also more convenient because you don't have to take a pill every day. All right, so let's talk ever so briefly. Oh, and then there's also, what do you call them? IUDs, intrauterine devices. So intrauterine devices come in two major forms. One of them is copper. And copper works in a number of ways, but ultimately it inhibits the ability to become pregnant, but could also potentially cause miscarriages. And then the other is, it's an IUD that's inserted into the uterus also, but it's basically just hormonal deposition drug. So it's going to act similar to like a Nuva ring in that regard, except you don't have to replace it very often. The Nuva ring you replace once a week. All right, so emergency contraception. Most emergency contraception is just a high dose of progesterone. So when you were asking earlier, you heard that if you take several pills at once, it's like taking Plan B. Yeah, because Plan B is basically just a higher dose of progesterone. Now, the thing about emergency contraceptive is that it only works for up to about 72 hours after intercourse. If fertilization has already taken place, then supposedly it will not harm the fetus. But there is a chance that it could make it less likely to survive. So there's some people have concerns about could it cause a miscarriage, and they would call that an abortion. But for the most part, supposedly, that's not how the drug works. And how does your body sustain a pregnancy anyway? It's to increase progesterone levels. So that's Plan B. Plan B is just one type of the emergency contraceptive, and there's a number of different protocols, but they all boil down to an increased dose of progesterone. Some of them are a 2-dose method, and then one of them is a 1-dose. So you basically take double the amount all in one time. The others you take it extended over 2 doses. So one day, one the next day. Any questions about that in general? Now, emergency contraceptive. Most of it is over the counter. What does that mean?
You just walk in and get it.
You just walk in and get it. So every now and then you'll see, news. You'll see news things like, They outlawed abortion and wherever. There's a run on Plan B. Everyone's going to the doctor to get Plan B. I'm like, it's over the counter. You don't even need to go see your doctor. The politicization of all of these things is just amazingly silly. How many remember the Hobby Lobby controversy? Yeah. They won't cover birth control. Well, it's generic. None of them cover generics. It's like,
Sorry, wait, isn't it like bad if you take a lot of Plan B?
why would you want to?
You take like 8.
No, like if you're using it as your main
Yeah.
birth control
Form of
method.
contraceptive.
Okay, define bad.
Like,
Unhealthy.
prevent like you to get pregnant and all of that. No.
Okay, so generally speaking, we don't think that hormonal birth controls inhibit a woman's ability to become pregnant afterwards, but following hormonal birth control, some women do have a harder time becoming pregnant. Now, was that something they already had, a pre-existing condition of some sort, or is that something that was caused by the contraceptive? It's hard to say. But what is Plan B, in essence, other than
Birth control.
Depo-Provera,
Yeah.
except you're taking it by mouth instead of, it's like, if you're gonna do that, you might as well just get
Birth control.
a longer term one, then you don't have to pay for it all the time. Unless you just don't want to see a doctor and you just want to buy it over the counter. I mean, I don't know. There's no real good data on that because it's not something that you would expect to be done. But hey, whatever. It's not a very good answer, I'm sorry. Yeah, but I wouldn't anticipate there would be a huge problem with that.
Do you think that IUDs are not safe? Because like I know there's a lot of controversy whether or not, because like my mom's friend like had like major like blood clots and bleeding and all this
Yeah.
stuff.
Okay, so IUDs are not without complications. It can also be very difficult to place one in a woman who's never become pregnant.
Oh.
Because everyone do like this. Okay, so that's pretty much what your cervix looks like. So there's a big ring of muscle, and then there's a tiny little hole. That's where the baby comes out. That's why it hurts so bad. So in order for the baby to be born, what has to happen? Okay, so that's got to open up, and then that big thick muscle has to thicken out. So the opening up of the hole, the os, is called dilation. The thinning out of that big thick muscle is called effacement. And we learned in Pathopharm 1 that one of the things responsible for that is prostaglandins. Remember that? Yeah. Now, when the baby comes down that canal, it stretches everything out even more, and then after pregnancy it begins to go back, but it's never quite as small as it was to begin with. So in a woman who's never become pregnant, sometimes it can be too difficult to get the IUD up there. And so that can be a potential complication. But sometimes they can migrate, and that's, or they can perforate, and so that's where you hear some of those horrible things coming from. But the copper in and of itself is not especially dangerous. There are, like with anything, it's a medical procedure and there are potential complications. Any other questions?
So it's going through into the cervix and then there's
Yes.
things are like
Right, so yeah, so it'll go up into the cervix. Here, let's do it this way. So here's the cervix, kind of here's the uterus, and there's so you put it up into here. It's a little device and it sits here, and then it has like these little wings that kind of hold it in place. Yeah. So, I know, it's pretty horrid. That's like the most terrible drawing I've ever drawn, even worse than my aliens. So, any other questions? All right, last thing we need to talk about is hormone replacement therapy. So hormone replacement therapy, it comes to a certain time in a woman's life where she runs out of eggs. Because you're born with all the ovum you're ever going to have, right? Okay, what happens over time?
shedding ones.
You use them up. And when you use them up, you have a need to have a menstrual cycle anymore. Nope. Yeah, because you've used up your supply. So that time is called menopause, and typically happens in middle age, around late 40s, early 50s. So during that time, as a woman is transitioning from having normal menstrual period to menopause, we call perimenopause. And that time is associated with a large number of physiological changes because her estrogen levels will go down, and then later on, her testosterone will also go down. So estrogen has a number of protective effects in women. It helps preserve muscle mass, helps to preserve bone mass, it helps with mood stabilization and temperature regulation. So as women are going through menopause, a lot of them will have symptoms, such as hot flashes and mood swings are kind of the big ones. Sometimes they'll have depression. So estrogen was discovered that if we give women artificial estrogen, we can reduce these things. And then we also realized that as a woman gets older and has less estrogen, she also has increased risk for heart attacks and also has increased risk of osteoporosis. Maybe if we give them estrogen, it will prevent those things too. As it turns out, it does help with osteoporosis. It doesn't seem to help with heart attacks. In fact, it might increase the risk of heart attacks. So there were a number of high-profile studies, the most famous of which was the Women's Health Initiative, where they decided that the study had to be stopped prematurely because of the increased risk of, I want to say it was cancer in this case. So overnight, women everywhere went off their hormone replacement therapy, and overnight their husbands went, okay. So anyway, the problem is that the WHI was never studying women who had hormone replacement therapy for the purpose of symptom reduction. It was studying it in women who had never had a heart attack to see if we could reduce the risk of a heart attack to begin with. So unfortunately, there's been no good studies that have actually studied what is the risk in women who are using it for using it for symptom reduction.
Wait, but if it can increase the risk so bad that they told all those women to go off it, why would anyone be on it?
They didn't tell them to go off it. The news came out. And overnight, women went, scared!
Oh, okay.
Was it necessary?
Maybe.
No. Yeah. The results are slightly controversial. And like I said before, there's no good evidence to suggest that a woman who's getting it for symptom reduction is at risk.
Okay.
But that study's also never been done. So I'll send you guys a big long article going through all of the studies and like what each one showed, and the ultimate, in the end, science is, I don't know. So I'll send you guys an article that reviews all that stuff. The important point is, today, the only reason that we would give estrogen therapy as a hormone replacement therapy nowadays is for symptom management. So there's a question that has to be asked. First of all, is the woman having symptoms? And if the answer is yes, she can have therapy. So then the next question is there a uterus? And if there's a uterus, what do we need to do? What?
I said remove it too. Remove it?
What? Well, you're going to give them estrogen in both cases. But how does having the uterus change things? If they have a uterus, we have to give them progesterone or progestin also.
It's almost like they're on birth.
It's almost like they're on birth control, but it's probably a slightly lower dose. Who cares? The important thing is, if a woman has a uterus, what do you need?
Progesterone.
You need to add progesterone into the estrogen. Now, one of the other things we should also mention is atrophy of the vulva and vagina. So one of the things that estrogen does is it helps to maintain the vulva and vagina. So as a woman goes through menopause, she'll often have atrophy of those areas, and that can lead to a fun symptom called dyspareunia, which means painful intercourse. So you can also use estrogen for that. And you can also use, they have like estrogen cream or gel that you can use just locally to improve just that one symptom. And one last thing we should also mention is that if a woman ever has a hysterectomy where they remove her uterus, a lot of times the ovaries will go non-functional within the next 5 years or so. So we call that a functional menopause. So even though she has ovaries, she can go into menopause much, much earlier than usual.
Wait, can you explain it one more time?
So, all right, so you've got ovaries out here, right? And what are the ovaries connected to? To the uterus. So if you remove the uterus, but you leave the ovaries there, you would think, well, the ovaries are still going to produce estrogen. But what will happen within typically about 5 years is that the level of estrogen that the ovaries produce goes dramatically down, and the woman goes into what we call functional menopause.
Early, possibly.
Yes.
If they're like close to that age, why wouldn't they just have like a full hysterectomy and get the?
It's a more invasive surgery with more risks. And if you have functioning ovaries for the next 5 years anyway. Yeah. So if they do a total abdominal hysterectomy, that's where they also take the fallopian tubes and the ovaries. That woman essentially goes into menopause overnight. So you'll also see hormone replacement being used in those types of patients. All right, any questions about all that stuff? All right. I don't feel like that was my best work. I've done better.
The lecture or the picture?
Yes. It's this room. It doesn't have the right vibe.